White cataracts are one of the more challenging scenarios faced by cataract surgeons. Because the white cataract precludes the view of the red reflex, it requires special surgical strategies. The major aspects of white cataract surgery are to avoid the Argentinian flag sign, conduct proper hydrodissection, and remove a hypermature or intumescent type lens. White cataracts have markedly hydrated swollen lenticular material, which then causes an increase in lens thickness and a relatively tense lens capsule. There are many publications related to staining of capsule to visualize the capsular excess during white cataract surgery. However, we have noticed that the dye only helps with visualization of the capsulotomy and that it cannot prevent capsular tearing. The most difficult step of cataract surgery in these hypermature intumescent cataracts is to perform a capsular excess without an extension of the capsular bag opening. How to open the capsule without a radial tear. It is important that a higher pressure in the anterior chamber than the pressure in the capsular bag is maintained to have control during capsular excess. Irrespective of the capsule staining, focus should always be on the 3 steps. First, overfilling the anterior chamber with the viscoelastic material to flatten the dome of the capsule should be done, which can reduce the risk of capsular tearing caused by increased intralenticular pressure in such cases. Second step is to make a firm initial puncture and create a larger flap to release the smoke-like milky white cortex. Third, slightly adjust the eye position for better visibility of reflection of capsular flap. Each time the flap is released, its edge should be elevated, making it easier to grasp the flap edge. Now, we shall discuss a bit about how to manage the unexpected radial tears. If a radial tear occurs during capsular excess, the first step is to calm down and take a deep breath. Next, attempt to stabilize the anterior chamber to reduce the stress on the tear and decrease the chance of the tear extending to the posterior capsule. Also, ensure that the OVD injection is started at the periphery and not in the middle of the tear. Then, using capsular scissors or a bend needle, make an incision circumferentially at the edge of the radial tear and restart a new tear using capsulotomy forceps, basically ignoring the radial extension. Whenever the capsulotomy is not continuous, extreme care should be taken for the following procedures. Once capsular excess is successfully completed, the next step is hydrodissection. Particularly in the white cataract with brunescent nuclear sclerosis, it is important to ensure that the entire lens cortex is separated from the lens capsule by balanced saline solution. Due to lack of visibility of the posterior lens capsule, hydrodissection is conducted based on experience only. Hence, let us take a look at the following steps and direction of BSS flow. Step 1. Cleaving the cortex from the posterior capsule. Insert the 27-gauge cannula under the anterior capsule by slightly lifting the capsular excess edge upward. Step 2. Terminate the BSS injection once the hydrodissection wave has completely crossed. In these cases, it is difficult to locate BSS, but when a slight forward bulge of the lens is noted, it is a sign indicating that sufficient quantity of BSS has been injected between the lens and the posterior capsule. The injection should then be terminated. Step 3. Using the tip of the cannula, gently depress the lens to separate the nucleus from the anterior capsule and to vent the fluid out. The cleavage of cortex from the capsule equatorially and anterior capsule allows fluid to exit from the capsular bag via capsular excess. Step 4. Rotate the nucleus within the bag using the cannula tip. Imagine a point on the axis of the lens. Rotate the nucleus around the fixed central point within the capsule in a clockwise direction. Pass the tip of the cannula under the right edge of the nucleus and hold it slightly lifted in a plane marginally forward to the anterior chamber. This will result in a free rotatable lens. The next step is to remove an intumescent lens. Due to the lack of a red reflex, removing an intumescent cataract is a surgical challenge. A divide-and-conquer technique can be used to debulk the nucleus, thus providing more space for future maneuvers. Nevertheless, doctors who prefer to chop the lens may have a problem reaching to the back side of the nucleus, which can be fibrotic and leathery. Large sclerotic lens can be partially separated on first chop to help in the strength and depth of subsequent chops. Besides, core separation is a very important skill. The second instrument and phaco tip should be placed up to half or 2/3 lens deep to allow for easy application of force at the deepest possible point in the nucleus, and to direct the splitting force in the most efficacious direction. Care must also be taken while creating the deep crack through the entire thickness of the nucleus. Pulling the pieces away from each other to crack the nucleus can transmit the pressure directly to the capsular bag. Once the segments of the dense nucleus are freely mobile, the nucleus should be divided into smaller fragments for secure emulsification. Every cataract is different, and thus the best approach is to be prepared. Successful management of white cataract is to follow a thoughtful and step-by-step approach that anticipates the challenges and allows the surgeon to surmount them.